Hello, my name's Dr. Alia Munir. I'm a consultant endocrinologist from Sheffield Teaching Hospitals, and I've got an interest in neuroendocrine tumours. I'd like to thank Neuroendocrine Cancer UK for inviting me today to speak at this educational webinar, and I'll be talking about reproductive health, menopause and hypogonadism in neuroendocrine cancer. I have no disclosures for this topic. So over the next 15 to 20 minutes, I'll go through the definitions of these conditions and run through what existing guidelines we have available, and then talk about the effects on reproductive health and sexual function of some of the treatments that we give for neuroendocrine tumours. In particular, I'll talk a little bit about menopause in women and also hypogonadism in men. And then I'll finish up with what we may need in the future. So just for the talk, I will be referring in the main to well-differentiated neuroendocrine tumours as NETs and high-grade neuroendocrine carcinomas as NECs. Now, this audience will be very familiar with neuroendocrine tumours, the increasing incidence of these tumours, and that some of these tumours do secrete hormones. In addition, some patients may have multiple endocrine neoplasia type 1, and this may have effects on the pituitary, and the pituitary is regarded as the master gland and can control not only growth, puberty, but also sexual function. Now, in neuroendocrine cancers, not only can quality of life be affected, but sexual function, reproductive health and family planning can also be impacted by changes to hormones. Now here, just for example, I show you the changes that medications such as somatostatin analogues can have on the gonadal system in a male, but also just for illustration in a female, and how somatostatin analogues can cross the placenta and then have an impact on the neonate. And we'll come on and look at this in a bit more detail. So currently, there are clinical practice guidance that are published for healthcare professionals to follow. And you can see here that there's guidance on management of cancers in general, in pregnancy, and for fertility considerations. And these are published by ESMO. These particularly look at diagnosis, treatment and follow-up. But in addition, there is a ESMO publication on fertility preservation and treatment in pregnancies in patients that have had cancers. In terms of the effects of neuroendocrine neoplasms on reproductive health and sexual function, I picked up a recent paper published last year, and hopefully we can go through some salient points from that today. So what about neuroendocrine treatments and fertility? Treatments in neuroendocrine tumours can include somatostatin analogues, and these have a anti-hormonal and anti-tumour growth effect, as well as a anti-vascular effect. And somatostatin itself has several functions, which includes effects on the CNS, in mood, but sexuality, anxiety, sleep, appetite and temperature as well. And we know from animal studies that somatostatin analogues can have an effect on sperm production. In women, we also know that there can be effect on ovulation in puberty, and as I previously mentioned, that there could be crossover in pregnancy, and this could in turn affect the pregnancy, but also the baby with low birth weights being noted. Studies have shown that there's a transient reduction in the uterine blood flow. There had been a suggestion from the Endocrine Society back in 2014 that if somatostatin analogues are required and conception is wanted, that these could be replaced with this short-acting drug, unless there were tumour control concerns. This data is mainly extrapolated from patients with acromegaly and pituitary tumours. Carcinoid syndrome in the context of a pregnancy may also affect the neurology of the fetus. Turning now to peptide receptor radionuclide therapy, this is of course radioactivity treatment, which is given when there's been progression of a well-differentiated neuroendocrine tumour on somatostatin analogue. And these patients have inoperable metastasized neuroendocrine tumours. Now, taking men firstly, it has been demonstrated that there is a decline at 3 to 24 months of testosterone, and that in general conception is not recommended during and 4 months after treatment. If necessary, sperm banking can be considered if this treatment is to be undertaken. And the gonads or the testicles are regarded as radiosensitive organs. Other hormonal markers are also noted to have changed during this time. With respect to women and PRRT, there's limited data. There is case reports of fertility after radionuclide therapy, but pregnancy is an absolute contraindication to treatment with PRRT, and breastfeeding is a relative contraindication, meaning that these are absolutely not recommended. There's no data on PRRT in pregnancy, and it's generally recommended that effective contraception should be used for at least 7 months post-PRRT, and that breastfeeding is not recommended after PRRT. Currently, there's no available indications of oocyte cryopreservation before PRRT. Once again, here one would recommend discussions in the appropriate age group of patient regarding contraception and family planning. So moving briefly to chemotherapy, here there is more detail on fertility preservation, and guidelines recommend discussions of initiation of fertility preservation and family planning prior to neoplastic medication. Chemotherapy and radiotherapy do trigger gonadal dysfunction, meaning that fertility is affected, and it can cause premature menopause and infertility in both men and women. There's no absolutely specific data in neuroendocrine neoplasms, but there is data on infertility caused by carboplatin and cisplatin and etoposide, which are the frequent drugs used in neuroendocrine carcinomas. With respect to platinum-based chemotherapies, preclinical models have shown that gonadal or testicular and ovarian toxicity occurs with fertility impairment and changes to epigenetic structures. With respect to etoposide, we know that there can be adverse effects on female fetus ovarian development, and that temozolomide can impair sperm production and reduce egg pools in females. Changes in semen have also been seen, but once again there are case reports about fertility and the birth of children after treatment with temozolomide. But again, these are case reports and are not recommended, and discussions about contraception in those groups is appropriate. Looking at targeted agents, there's scarce data on gonadal function. We do have some data on the mTOR inhibitor everolimus, and that this can affect sperm production and cause sperm abnormalities. And again, it's recommended that contraception should be used during and at least 8 weeks after treatment. With sunitinib, it's known that there can be an impact on ovarian function. Turning now to sexual function or libido or sex drive, this is frequently left undiscussed in oncology visits, and the effect on sexual function and libido and satisfaction in both men and women can be considerable, and this can have an effect on quality of life. It's found that this is more frequent in men, with 29% versus 6% reporting sexual dysfunction and dissatisfaction. So let's have a look at menopause now in women. In terms of available guidance for how to manage menopause, we turn first to the British Menopause Society, and there is some recommended standards of practice of management of menopause in women, with some references to women that may have had breast cancer. And there is also practical guidelines which have been published on the assessment of management of menopause after breast cancer in the oncology journals. And I've just pasted some examples here of those guidelines. So menopause in women is when periods stop due to lower hormonal levels. Typically this can happen between the ages of 45 to 55, and in the UK the average age is thought to be 51. If it occurs earlier than that, it's termed premature menopause and very early premature ovarian failure. So menopause can be natural, or it can occur because of surgery or treatments like chemotherapy. The term perimenopause is when there are symptoms of menopause, but the periods haven't stopped. These symptoms can have a huge impact on the quality of life and also have an impact on mental health. So what are the symptoms? These can be changes to periods. Mental health effects can include mood swings, anxiety, memory problems, concentration issues, or so-called brain fog. Physically, there can be hot flushes with night sweats, feeling hot and cold. These effects can be from the torso to the face and neck, and there may be difficulty sleeping, palpitations, headaches, migraines, and muscle and joint pains. And the initiated know that there can be frequently some overlap in symptoms of carcinoid syndrome. Weight gain, a change in body shape, skin changes, skin dryness, vaginal dryness and itching, discomfort during intercourse, and recurrent UTIs are also some of the symptoms that are reported. What do we know about menopause in neuroendocrine tumours and its management? So there is a paucity of data. However, interestingly, it has been noted that mesenteric lesions have expressed estrogen receptors. And when it comes to HRT and discussions regarding HRT, this should be individualized, because there are some non-hormonal options for HRT after breast cancer, but also there is a number of other options for women generally in terms of HRT, and I'll come on to show you some of those. Things that do need to be considered are what requires treatment and management with menopause, and also the risks and the benefits of treatment, and whether it's going to be long or short-term treatment, and the available preparations. Generally with HRT, there are improvements seen in the so-called vasomotor symptoms, so the flushing and the sweating within 2 to 3 weeks, but more so at 3 to 4 months. And often preparations need reviewing and may need switching, or doses may need adjustment. But what we do know generally for menopause and HRT, is that there are cardiovascular benefits, skeletal benefits in terms of osteoporosis, and the risks regarding breast cancer we can discuss further. So we do know that in general for women that don't have an underlying malignancy, that HRT is safe and improves quality of life, protects the skeleton and the cardiovascular system. And for virtually all women, regardless of what any other diagnosis may be, that they will benefit for treatments for urogenital atrophy using lubricants, moisturizers, and the use of vaginal estrogens is in the main safe. The only caveat for this would be any patients on aromatase inhibitors. And the estradiol or estriol, which is weaker, can be given as a cream, pessary or gel. In addition, there are other treatments as well, such as DHEAs, which is the precursor converted to estrogen and testosterone, is minimally absorbed. And there are future directions where perhaps laser therapy could be an option. And in addition, there are new drugs in the pipeline for the future, which are neuroendocrine antagonists, and I list a couple of them here. Many people are offered antidepressants for menopausal symptoms, and in fact low-dose antidepressants like slow-release venlafaxine or low-dose mirtazapine can be very effective for sleep disturbance. Antimuscarinics such as oxybutyn can also be used to reduce sweating, and clonidine is the only non-hormonal that's licensed for this as well. Now, there is data on HRT in patients that have had breast, bladder, ovarian and gastric cancers, and we do know that some gastric tumours express estrogen receptors, as well as the data I previously mentioned about mesenteric lesions expressing estrogen receptors. And here you'll simply see this cartoon with the numerous different preparations that exist of HRT. And I'm not expecting anyone to read these pages, but this is taken from the British Menopause Society standards, and you can see that now there are many preparations of HRT, and these can come as oral, transdermal, subcutaneous, vaginal, intrauterine, as a gel pump, sachet, spray, patch, and there really is a lot more to HRT than meets the eye. And certainly I'm fortunate that we do have menopause specialists where I work, and where needed we can discuss patients in their MDT and also get consultations. And for example, transdermal or topical estrogen is pretty safe in most patients. What about treatment of male hypogonadism in neuroendocrine tumours? So, hypogonadism or reduction in the male sex hormone is commonly seen in neuroendocrine tumours and has been seen after peptide receptor radionuclide therapy. And in a study that I reviewed, 16 out of 42 men had developed hypogonadism after PRT, 7 of which had what we call primary testicular failure, and 9 had secondary, so meaning coming from testicular failure or the pituitary. And what happens is the testicles fail to produce testosterone or sperm, and there can be numerous other causes of hypogonadism as well. And I've listed some of them here. Current guidelines have been updated, and last year the Society for Endocrinology published testosterone replacement therapy guidelines for men. And this is a really useful reference. And the main things with testosterone replacement to be aware of are effects on the prostate, polycythemia, and cardiovascular disease. So in terms of the goals we should have in our mind when thinking about hormone replacement in patients that have neuroendocrine tumours or other cancers are tailored to the individual, and they look at fertility, family planning, pregnancy, menopause and hypogonadism. And frequently it's about maintaining a good quality of life and controlling symptoms without deleterious effects or side effects. In terms of neuroendocrine tumours, we do need to have a look at specific data for neuroendocrine patients and ensure that symptom dismissal or overlap doesn't occur and recognition of carcinoid versus menopause is appropriate. I think future studies and randomised trials are indicated, and in particular looking at women's health, and there's certainly some initiatives coming from women in neuroendocrine tumours as a subgroup of ENETs. And also there's a lot of work going on looking at late effects of cancer treatments. And certainly menopause has been a huge buzzword over the last couple of years because of publicity, and we certainly have more inquiries regarding menopause now, and this can only be a good thing. So I hope I've gone through the definitions and the guidelines that exist for consideration of reproductive health, fertility, menopause and hypogonadism, and shown you that there are guidelines written for patients with cancer, but there's a paucity for those written specifically for the patients with neuroendocrine cancer. I think what we have to remember is that we should always be individualising care, and that we do need much more awareness and more studies in this area. Many thanks indeed for your attention. I'd be delighted to take any questions in the Q&A.